Okay, good evening, ladies and gentlemen. For those of you who don't know me, I'm Trevor Macmillan, and I have the privilege of being the Vice-Chancellor here at Keele University. It's a very great pleasure to welcome you to the inaugural lecture to be given very soon by Jim Nolan. I feel like the opening script for these inaugural lectures gets a little bit repetitive for those that come quite often, but it is genuinely true that these lectures are a very, very important part of university life. And indeed, at Keele here, we are one of a relatively small number of universities that have maintained the tradition. A lot of other universities have either done away with inaugural lectures or turned them into a sort of mini symposium rather than an individual event. But I think for us, it's a very good opportunity to highlight some of the world-class research that goes on in our institution, and on this particular occasion, a very good opportunity for us to emphasize the very close collaborative relationship we have with some of our partners, in particular within the NHS. It's also, though, clearly, indeed, all about the individual. In this case, Jim Nolan, we were discussing already. These are not easy lectures to put together. I don't know many of you in the audience, but I suspect we will have some people in the audience who will know every word about what Jim is about to talk about and who will be able to critique it in every detail. And there will be some of us who actually do not know very much of the background. And so, to be quite honest, he could almost say anything he likes, and we would absolutely implicitly believe it. So that's quite a fine line to tread. But all in all, the key thing, to be honest, is that he will keep us entertained for the next 50 minutes or so, and I'm sure he'll do that. Now, at this time in the proceedings, it's normal that I try to summarize the curriculum vitae of the new professor who's about to talk to you. On this particular occasion, Jim's CV, I have to say, is one of those that I just genuinely cannot give justice to in the short time that I have available. So I'm actually going to bottle it. I'm going to wimp out and I'm going to give a very, very quick overview of his history and then hand over to Jim so that he can talk about it himself. So Jim qualified from Leeds in 1983. He trained in cardiology at the Royal Free in London, the Royal Infirmary in Edinburgh, then in Amsterdam, and then back to Leeds before taking up his current post as a consultant interventional cardiologist in 1998. During his appointment in Amsterdam, he was trained in novel techniques that facilitate safer coronary intervention procedures. He's had a major role in research, education, and training into these new techniques, and as a result of his academic and education initiatives, UK practice has evolved into a new model of coronary intervention. He carried out research into chronic heart failure and was awarded his MD from Leeds University in 1996. Despite being a full-time NHS clinician with no academic sessions, Jim has an enviable research record. His principal research interests relate to heart failure and the use of transradial access for coronary intervention, and he has established an internationally renowned cardiac research program and has published a large number of peer-reviewed papers, including highly cited pivotal studies. For those of you who think about such things as the H-index, which is a measure of how many times other researchers cite his work, that number is 25, which I can assure you might be a meaningless number to many of you, but 25 is the sort of number that even full-time researchers would be very, very proud to have. Jim has contributed to many textbooks and as a regular lecturer at national and international conferences. He's served on the editorial boards of major cardiac journals and is a member of the governing council of the British Cardiovascular Interventional Society. His work has genuinely stimulated a major change in UK practice, with most centres now using radial access for interventional procedures, and that has led to very important benefits for patients. Jim has a very, very important place in the regional and national clinical community and indeed in the work of this university. Tonight he's going to talk about identifying patients at risk of early death from heart failure, which at a personal level is of great interest, having just lost one of my closest friends to a sudden heart attack just 6 weeks ago at the age of 62. And he's also going to talk about the role of access site for coronary intervention. So can I therefore formally welcome Jim Nolan, Professor of Interventional Cardiology, to the stage and invite him to present his inaugural lecture, Modern Treatment of Heart Disease, Can We Do It Better? Thanks, Jim.
So, it's a very serious world we live in now. Doctors are under intense scrutiny. We're always made to declare any possible conflicts of interest we have at the beginning of a lecture, so here's mine. Stoke City supporters or Everton supporters won't recognise this trophy. It's the 2005 Champions League trophy, of course, won so memorably in Istanbul. I can hardly believe it was 11 years ago. In some ways, it's ruined my football supporting life because nothing can ever be that good again. So when I was looking back through the things I'd been up to over the years, I was struck by how everybody's research career does start somewhere. And when I was a cardiology registrar at the Royal Free, we had a vet working in the department with us. He'd come to try and learn how to do some of the techniques. And he told me one day he had a little dog that kept falling over whenever it tried to run because it had complete heart block. And we had a couple of pacemakers lying around that we'd had to explant from people. So we kind of run one under the tap, washed it down, sterilised it, went up to the veterinary hospital, popped it into the dog. And we were up and running, reported the case. So I spent a bit of time doing these pacemaker procedures in dogs before I kind of realised that there probably wasn't a long-term career in that for me in clinical cardiology and practice in people. So when you think about what people die from, 2/3 of the people in this room will die from cardiovascular disease, commonly from ischemic heart disease. Ischemic heart disease being narrowings of the coronary arteries. And the things that kill them are blockages of the coronary arteries. They cause symptoms, they can occlude, they can cause heart attacks with all their complications, or patients can survive with damage to the heart, and they have to live with chronic heart failure. When I went up to Edinburgh to do my research degree, I was interested in looking at heart rate behaviour as a way of examining cardiovascular health. As you sit there running along with a heart rate of about 60 beats a minute or so, you might think that that is a rock-steady thing, that your heart rate doesn't change. But in fact, here you can see one human individual's heart rate fluctuating quite widely over the course of 3 or 4 minutes. Your heart rate is constantly changing. You know, you stand up, you sit down, you watch the football, West Ham score a winner in the last minute of extra time, whatever it may be. The missus tells you off for not washing the dishes quick enough. You're constantly varying your heart rate, and there's a complex neurological system that controls regulation of heart rate here. Up here is the cardiovascular control center in the brainstem. It's what sports scientists would call the monkey brain. It's buried deep within the brain, at the base of the brain. You've got no real conscious control over what's happening here, but a complex set of nerves run to and from this and control your heart rate. And they're influenced by temperature, standing up, sitting down, all sorts of things, really. And if you can measure this change in heart rate, you can get an idea of the functioning of the autonomic nervous system and the health of the cardiovascular system in that individual. So when I went to Edinburgh, we developed a way of counting the amount of variability that occurred over a 24-hour period from a little tape recorder. And the first thing we did was to study some normal people and people with various diseases to see if we had a reproducible technique. So if you did the measurement on a Tuesday and then on the following Wednesday, did you get the same results? And if that's so, the results will be clustered closely along this line, and you can see that we had a very reproducible technique. There are various numerical ways of analysing that in more detail, but after publishing this paper, we were pretty confident that we had a good way of analysing heart rate variability and assessing autonomic function. The next thing we did was we looked at patients with severe coronary artery disease, but who had never had a heart attack, whose heart was functioning well. And these two parallel lines are the normal range, and the dots are the patients that we studied. And most of them are well within the normal range. There's always a few outliers. So we knew that if you had coronary artery disease on its own, you didn't have abnormal cardiac regulation. Then we looked at a group of patients with chronic heart failure. This is the normal range again, the two parallel lines, and you can see here about 60 to 70% of the patients fell well below the normal range, so they had reduced heart rate variability, and this was probably an index of the severity of their general condition. The patients with the lowest heart rate variability were the patients with the lowest ejection fraction. So if your heart was functioning poorly, you were down here. If your heart was functioning quite well, you were up here, and your variability was preserved. The next thing, I mean, that series of studies, along with some others, made up my MD thesis. And when I left Edinburgh and I went to Leeds, I wanted to do another study to see if we could link this to outcome and prognosis in heart failure. And, you know, for any of the medical students, it's quite an interesting story. I went along to the senior academic cardiologist and asked them if they wanted to work with me and help me to do this study, and the answer was no. I asked if I could borrow a couple of ambulatory ECG monitors to do the study, and the answer again was no. So I waited till the professor went away on his holidays, and I borrowed the two ambulatory ECG machines from the cupboard. We got a £7,500 grant to buy a couple more, and I contacted, these are my friends really, I got on the phone to my friends in Nottingham, up in Edinburgh, another guy in Doncaster, and we recruited about 500 patients with chronic heart failure. We measured their heart rate variability. We followed them up for a couple of years. And the patients down here who had very abnormal heart rate variability didn't do very well at all. And after 18 months to 2 years, 70% of them were dead. And the patients up here who had preserved heart rate variability, in contrast, did pretty well and weren't far off an age-matched population who had normal cardiac function. It's an interesting paper, you know, the background to it about it being done for £7,500 without any involvement of the local academic people. The journal it was published in, Circulation, the average number of citations for papers published in that journal would be 15 in a year, and this paper has been cited over 1,000 times. So it's a significant, pivotal and fundamental piece of heart failure research. Of course, you know, knowing about it is one thing. Can you do anything about it? We studied a group of patients before and after putting them on an ACE inhibitor, captopril, and we showed that we could improve the heart rate variability of the patients by putting them onto captopril. So we did have a therapeutic tool that we could use for these people. So at the end of that group of heart failure studies, we knew that autonomic control of heart rate is deranged in heart failure, and you can investigate it reliably by heart rate variability analysis. The magnitude of derangement is related to the severity of the condition, and it can be modified by drug therapy, and it's strongly predictive of survival, and it can be used to guide treatment decisions. After that, we've done a whole series of other things that are ongoing right up to now. 14 subsequent peer-reviewed publications. We looked at the different ways people die, different prognostic factors. We followed them up for a long time. We looked at different heart rate variability analytical techniques, and it's kind of interesting, really. The first thing that we did was I drove up to Edinburgh, collected all the tapes. They were on cassettes, so there's nearly 500 cassettes. I drove down to London, and I met the professor of cardiology from Virginia, who flew over, handed over the tapes to him. He bundled them all up, took them on a flight back to America the next day, drove them down to a NASA laboratory in Miami, and they ran the tapes through a supercomputer. It took months to do a complex analysis looking at chaotic behaviour, and we were able to show that that analysis was even better than the heart rate variability technique that we'd done through working with NASA. In a kind of British way, this paper was published just last year. We then thought, well, could we do it quite easily? Could we look at any other things? And we thought we might look at heart rate range, so the difference between peak heart rate and minimum heart rate. And we thought that if that was wide, that it would represent preserved autonomic function, and if it was narrow, it was probably abnormal autonomic function. And we correlated the two measurements together, heart rate variability here and heart rate range here, and you can see there is a relationship between the two. And then we looked at whether this related to prognosis in the same way as heart rate variability. This is mortality here. Patients with a narrow heart rate range were dying fairly frequently, and patients with a broad heart rate range survived very well. So at the end of that, the conclusion was that you don't really need to do the complex supercomputer analysis with NASA. You can just do a 24-hour tape and look at the difference between the maximum and the minimum heart rate. It's a bit like when the Americans started sending astronauts into space and they spent billions of dollars developing a biro that can write in weightless environments, and the Russians gave their cosmonauts a pencil. So you can do it pretty simply. We did some other things with various other groups. Quite a number of patients in papers in chronic liver disease. Last year, published some work in looking at different types of exercise training, chronic respiratory disease, myocardial infarction, tropical diseases. It was quite interesting. We studied a group of squaddies who'd been to Belize and came back with a horrible worm infection of their skin. And we thought that the treatment was a bit cardiotoxic. So we did study them, and we found that there was a bit of cardiotoxicity in what we were doing to them with the treatment for the worms. But if you don't treat it, the worms spread through your body, and they eventually get into your eyes, and they start to swim around inside your eyes. You can see them swimming backwards and forwards in front of your eyes. So personally, I'd take the toxic treatment rather than have some worms swimming around inside my eyes for the next few years. So that's the heart failure work in brief. I wanted to talk in more detail about the treatment of coronary disease through stent implantation. Now, this is an angiogram of one of my patients. This is a catheter that's inserted into the vascular system, and it's positioned at the ostium, the origin of this coronary artery. And the black stuff is dye running down the artery. You can see here a very narrow segment of the artery. And we can treat this by a technique called coronary angioplasty. We can thread a wire, it's 14 thousandths of an inch in diameter up the artery. We can position a balloon into the narrowed section. If we blow it up, we leave this little metal coil behind. We push the narrowed segments of the artery outwards and relieve the narrowing. You can see here the balloon inflated across the narrowed section of the artery, and bingo, it's gone. So it's a very effective treatment for coronary artery narrowings. One of the problems is, how do you get the catheters into the heart? Traditionally, the catheters have been introduced into this artery in the groin, the femoral artery. It's a huge artery, 6-8 millimeters in diameter, but there are problems. If you puncture this artery, it's the only arterial supply to the leg, and if you block it or damage it, the patient's got no blood supply to their leg. It's next to a very big vein, and it's next to an important nerve. It can be very difficult to compress. These are some pictures of patients who've had catheters put up their femoral arteries. I collected these pictures in 2 weeks at North Staffs. Inside those big bruised things are things like this. It's like kind of jelly. If this gets infected, it's a disaster. This is an infected hematoma. This was a fatal complication. Other things that can happen are you can get bleeding, uncontrolled bleeding from these punctures, and if it happens into the abdomen, this is a CT scan of a patient who came to our catheter lab, walked in, had a catheter put into the femoral artery and an angioplasty performed, and had a blood pressure of 70 at the end of the procedure. Went straight to CT scanning. This grey stuff here is 60% of the patient's circulating blood volume within the abdomen from a femoral puncture. The bladder's squashed and pushed out the way. This is the bowel pushed out into only half of the abdomen. You can see how this can be not a very good thing. Now, when I was in Leeds, we had these problems all the time. I spent most of my life down on the ITU or pressing on femoral arteries or trying to deal with the complications that we were causing to our patients who were walking in for procedures. The femoral complication rate was somewhere between 10 and 20%. So 1 in 10, 1 in 5 of the patients that we were supposed to be helping were having horrible femoral complications. If you have one of these femoral complications, these are the patients who had a bleeding femoral complication. These are the ones who didn't have them. You're much more likely to die, 10 times more likely to die. They're not things that you want to have. It's not a benign phenomenon. The first thing that we did was look at whether we could do the procedures from the arm. This is the brachial artery in the arm. It's quite a big artery. In order to do the procedure, you do have to cut down to this artery, make a hole in it and sew it up afterwards. It's not necessarily easy to do, But we did do a study where we compared complications for femorals with complications for brachials in anticoagulated patients, and we were able to significantly reduce the rate of access site complications by going to the brachial artery. The problem is, it is hard to do. You look at this picture and you've got an artery coloured red, a vein coloured blue, and a nerve coloured yellow. Well, I can tell you, when you look down there, everything is exactly the same colour. You know, you pull this artery out, you know, you're looking at it and you're thinking, is that the artery or is it the vein? Is it the nerve? You know, it's quite difficult to do the procedure. Vascular surgeons would be horrified at the thought of a cardiologist doing this. So we could do it in Leeds. The guy I was working with was very good at doing it, but in order to do brachial procedures well, you've got to do thousands of them. If you don't do many, you're looking at an 8 to 10% incidence of complications from the brachial cut down, never mind the risk of the femoral procedure. When you get down here and you've done 1,000 or so, it's okay, but it's just too hard to do and it takes too long. This is a picture of a patient who's had a brachial cut down procedure here. You can see, and the only anatomical difference between a man and a monkey is that the man can oppose his finger and thumb, the opposable thumb. It's the only anatomical difference between us and a monkey. So this person came to the cath lab, had a brachial cut-down procedure, and had a complication. And afterwards, the doctor damaged the median nerve, pulled it out, damaged it, thought it was the artery. And afterwards, he's asked to oppose his finger, and he can't do it anymore because of the damage to the nerve. So this is a person who's gone for a coronary angiogram, and his cardiologist has turned him from a man into a monkey. I can tell you that patients don't like that. So brachial access is not the answer. We gave up on that one. And while I was there, these guys in Amsterdam at the OLVG hospital published this data. So at the same time, we were having this 10 to 20% rate of major femoral vascular complications. These guys were doing the same procedures in exactly the same way with the same antithrombotic regime, and their rate of vascular complications was 0%. And when I saw this, I was amazed, really. I wanted to know whether it was real. I went to a course that they were running. Their patients came into the cath lab, they had the procedure, they put a little bit of compression on, and they walked out of the cath lab. I was really impressed by what they could do, and I was fortunate at the time that there was more money in the NHS, and I was able to go over to Amsterdam for 6 months to try and learn how to do the radial procedures. And the reason they're safer is because of simple anatomy. This is the radial artery. It's very superficial, so it's easy to puncture. It's a bit small. It's about half the size of the femoral artery. If you puncture it and you get bleeding, you'll see it because it comes out. It can't disappear into a body cavity very easily. It lies over the bone. If you feel where your pulse is, you can easily compress it because it's overlying a bone. And the other thing about it is that the hand has a double blood supply. This is the radial artery, but there is an ulnar artery on the other side. And the two arteries have a complex intersecting vascular system. So if you do block the radial artery, it's very rare that it would have any significant ischemic complications. So I spent 6 months in Amsterdam, and at the end of it, I'd learned how to do the procedures. I mean, I did learn that Amsterdam had a variety of different architectural and cultural things going on. Here's some examples. I didn't go to any of these places. I've got these pictures off the internet. I did notice that on a Friday and a Saturday night, 99% of the British males in Amsterdam were dressed like this. It's some kind of bizarre marriage ritual in 2016, practiced by male British people. I came back and in 1998, end of 98, we started doing the procedures at North Staffs, and it took a few years to collect the data, but this is the data that we published in 2003 on the first 1,000 cases that we did. So in 1,000 cases, remember that we were running a complication rate then that was very high. We had only 3 complications. One patient got a little pseudoaneurysm. I'll show you a picture of that later. And 2 patients got what we thought were infections. They were, in fact, reactions to the sheaths. So 0.3%. So that was a marked improvement on what I was used to when I was a senior registrar in Leeds. And the procedures didn't really take any longer, 26 minutes as opposed to 22 minutes for the radials and femorals. Angioplasties were identical procedural duration. And kind of at that time when we were doing lots of femorals, the department, 85-90% of the procedures are radial now. But at that time when we were doing lots of femorals, we had a kind of 2-tier society going on in the recovery area. This is time to mobilization, so when the patients are up and about and walking around. So for the radial patients, it was 20 minutes. 20 minutes after you've finished, you're walking around. And the femoral patients have to lie flat on the back for 4 to 6 hours. So these guys are, you know, lying down, trying to drink coffee out of one of those baby cups with a little spout, covered in crumbs from some terrible NHS sandwich they're trying to eat while they're lying flat. These people are wandering around, switching the TV over, watching Holmes Under the Hammer, switching it over to Test Match Special, whatever they want, really. Occasionally helping to squeeze a blood bag while one of these gets taken down to CT scanning. Doing a bit of light portering duties. I thought that my colleagues in the greater cardiology community would be pleased, and they would think that this was a good thing for patients and they would all take it up. But that really wasn't what happened, and there was a lot of opposition to what we were doing at North Staffs. People didn't like it. It was a challenge to them. They couldn't do it. They didn't want to do it, really. So they had a variety of things they said. They said, we're not convinced. You only did easy patients. So if you did any more complicated patients, you wouldn't get those good results. So we published this a couple of years later. Ted collected this data. We did 104 patients who had rescue angioplasty. So at the time, this was before primary angioplasty, and we used to treat heart attack patients with blood thinners, potent blood thinners. And if they didn't work and the blood flow didn't return in the artery, we'd take them into the cath lab and do an angioplasty to unblock the artery. And these patients have a 50 to 60% rate of those femoral complications that I showed you earlier. But the radial vascular complication rate in this high-risk population was 0%. So we were able to do them without jeopardy. Some patients are quite difficult to do. This is a patient with a very high body mass index who has 2 mechanical heart valves, 2 metal valves. They're on warfarin. You can't stop the warfarin, and they need to have a right and left heart catheter. And traditionally, we would have put the catheters in from the femoral approach, but here we've got a radial puncture, and we've punctured an arm vein. We haven't stopped the anticoagulation. We studied a group of these patients, a small group, and we found that we could do the procedures successfully, 96% success rate. They took us a bit longer. They don't take us longer anymore. This was right at the beginning before we'd learned how to do the venous punctures well, and that the radiation doses were the same as the femoral group. And we had 0% vascular complications in this group of very high-risk patients. More recently, we've looked at patients with cardiogenic shock having radial in red or femoral angioplasty, and there were 7,000 or 8,000 patients in this study. And what we found was we could do the patients with cardiogenic shock. These are the sickest patients we look after. They're in the middle of having a very big heart attack. They're so sick, their blood pressure can be 50 or 60. You know, they're not well people. If we can unblock their blocked arteries, we can make them better. This is the survival rate for the patients done radially with shock, and this is the survival rate for the patients done femorally with shock. So in the very sickest patients, we could do the procedures, and we got better results than the femoral operators. The next thing opponents said to us was that radial procedures are too difficult to do. And they can be difficult. The artery can be small, you know, it can be 2 millimeters in diameter. It can be smaller than the caliber of some of the catheters. This is a radial artery with a long segment of intense spasm. And so radial spasm was a problem at the beginning of our experience. This is some data that Ted Lowe collected early on. We did ultrasounds of the right radial artery, the left radial artery, and the 2 ulnar arteries. And in blue is the diameter before we started the procedure, and in red is the radial diameter after we'd given some sublingual GTN. And we consistently got a 15 to 20% increase in radial artery diameter. More recently, we've looked at whether that's beneficial or not in a large analysis of nearly 9,000 patients. This was the rate of radial spasm for the placebo-treated patients. This is for the rate for low-dose nitrate, and this is the rate for high-dose nitrate. So if you give GTN, you make the artery bigger, and you don't get spasm, 2%. Makes it easier to do. Once we'd sorted out what to do with radial spasm, we still experienced some difficulty in passing catheters up the arm in some patients, and we didn't originally know why that was. So we started to take angiograms of the arms. This is a normal arm angiogram. This is the radial artery, this is the ulnar artery, this is the brachial artery. Keep away from there. And this is quite a normal patient. And once we started looking at patients, we found there were other things going on. You can see this radial artery runs right up here before it joins the brachial artery. So this is a very unusual high bifurcation. This is a patient of mine who we couldn't get up either arm in this patient. There's extreme tortuosity of both radial arteries on both sides. This is a big 360-degree loop of the radial artery. You can see that it became difficult to navigate equipment around there to do your coronary angioplasty. Once we'd kind of noticed this, we started to collect data, and we studied about 1,500 patients, published the data in 5 or 6 years ago. And what we found when we systematically collected the data on these 1,500 patients was that 86% had normal anatomy, 14% had something abnormal. Commonly, it was a high bifurcation, but there was also an incidence of loops, tortuosity, or other variations. It was more common in the older patients, and it was more common in females. So now we routinely shoot an arm angiogram. And we know that those anatomical variations do have different implications. The failure rate for radial procedures with normal anatomy was less than 1%. If you have a loop, at that time, even for experienced operators, the failure rate was 40%. We're much better at dealing with them now. So what we do after collecting this data is we shoot an arm angiogram in everyone. If you see a big 360 loop, you've got the option of bailing out and doing a femoral puncture or puncturing the other side. The next obstacle that was put in our way was you get too much radiation from radial procedures. Now, radiation, it can be an issue. This is an early X-ray machine. There's some electrical gubbins in this big wooden thing here that generates the X-rays, and they come out of here. They pass through this man's hand and through this here, this kind of viewing thing. This guy's looking down, he sees the X-rays down here. After they pass through here, they pass into this man's head where they bounce around randomly for a while before exiting in God knows where they go. This is the very first X-ray that was ever taken. Mrs. Rontigen's hand, 1895. These are the hands of one of the early X-ray pioneers. You can see what happens if you put your hand in the main X-ray beam for a while, so you can kind of understand why Mr. Rontigen said to Mrs. Rontigen, stick your hand in there, love, for a minute, it'll be fine. Yeah. Marie Curie, I think, had an arm amputated before dying of a hematological malignancy, and it was very common for the early radiation pioneers to do that. It's important not to get too paranoid about radiation. It's all around us, really. This is a radon map, a radon gas map of the UK. The dark areas are places where there's lots of radon gas, which contains a lot of radiation. So in these mountainous areas, the Lake District, North Wales, or coastal areas where there's lots of rocky outcrops, you get a lot of radon gas. If you live down here, the council will pay to have a sucker machine to extract the gas from your house. I don't think so, not for me. Altitude is another factor. This is the back of my head, heading to the summit of a 4,000 meter peak in the Alps. It took 2 days to get to this point. When I looked along this ridge, I kind of regretted spending that 2 days getting to that point, because if you fall off here, if you slip down one side, or your friend does, you've got to jump off the other side to stop the whole process from happening. So if you move from New York to Denver, which is at 8,000 feet, you get about 30% more radiation every year. And of course, proportionally, as you go up higher, because the atmosphere thins, you get more radiation. There are other environmental sources of radiation. You get about 10 microsieverts every day. Share a bed with another person, you get an extra 0.05%. Get more if they're eating a banana while they're in bed. Lifestyle factors can be important here, perhaps if you're Hugh Hefner in the Playboy Mansion, you've got 7 or 8 people in there, it can be quite hazardous in terms of radiation exposure. Look at a computer monitor for 12 hours, you get a microsievert. For the eco-warriors amongst us, if you're living within 50 miles of a nuclear power plant for 12 months, you get an extra microsievert. Unfortunately, if you live near a coal power plant, you get 3 times that much. Not very important in the UK, which is now a post-industrial wasteland. So compared to these things, radiation in the cath lab can be quite hazardous. So here is the amount of radiation you get from a chest X-ray, 2.5 days of extra background radiation. And down here, an angioplasty is 10 years worth of extra background radiation. You can see if you have 3 or 4 angioplasties, you have some diagnostic angiograms, one of them is really complicated, you can get a lot of radiation in the cath lab. The patient can get a lot of radiation. And that, you saw that man's hands, the early radiation pioneer, but this can happen in our patients. Injury to the skin. Here's another patient who had an angioplasty. The doctors didn't move the tube around enough. It was a difficult procedure. Skin breaks down, has to be grafted. It's not a good thing to happen or to do to someone. This is a patient's arm who was exposed to too much radiation during an EP procedure. 6 months down the line, this was still the situation. So radiation can be pretty bad for you. This was published a few years ago in Heart. These are hairless legs. The hair's dropping out of this cardiologist's legs. Most of the radiation comes out under the table if you don't wear shin pads. The hair drops out your legs. Underneath that hairless area of the legs is bone marrow. And if you get a sizable dose of radiation, you run a risk of getting cancer. So if you're young, when you get a dose of 100 millisieverts, and you can't get that much from cardiological procedures, then you've got a 1 to 2% chance of dying from a radiation cancer. Most of our patients are down here and the risks are much less, but the operators, the people working in the cath lab, are in this zone, and they need to be much more careful with radiation than habitually they have been over the years. This is a report from Eurointervention of 30 interventional cardiologists who died from brain tumours. All of them were left-sided. It's the left side of the brain is the part of your head that's closest to the X-ray source. So it's clear that there's possibly an important relationship there. This was a study looking at lens opacities in normal people who don't work in the cath lab, not many, less than 9%. And here in cath lab nurses and interventional cardiologists, half of them had lens opacities that were directly related to radiation exposure. So the early access site radiation literature it reported an observed increase in radiation measurements in the radial groups, but the studies were really badly performed. They were observational, poorly controlled. There were major differences in the patients and the procedural groups. And it's important to remember that statistical association is not the same as causation. So if you look at 100 radial patients, compare them to 100 femoral patients, and the BMI is higher in the radial group, as it commonly was, then you will find more radiation in that group generated just by patient characteristics. So we set out to study radiation exposure in a well-controlled way. We wanted to minimize patient-related variation, so we only studied first-time diagnostic angiograms. We wanted to minimize the influence of radiation generation protection protocols, so we used fixed the same radiation protocol for every patient, and we matched the operator's expertise, so we had some experts who'd done a lot, and intermediate people who'd done a medium amount. This is what we found. Fluoroscopy time and access site. The radial group's red, the femoral group's yellow. There was no difference in the amount of time that the doctors had their foot on the pedal. This is the operator radiation exposure. There was no difference for the radial or femoral group. The trainee, of course, got more radiation, generated more radiation than the experts, but there's no surprise in that. And the patient radiation doses for either access site were identical. Again, the trainee had a higher measure. Of course, if you took the expert femoral operator and compared his measurements with the inexpert radial operator, you'd find a difference. That's what was going on with the rest of the literature. The groups weren't well matched. So we published really the first paper that showed no difference in radiation exposure, and that was diagnostic angiography. Here you can see for single and multi-vessel angioplasty, the fluoroscopy times were the same, and here the radiation dose for radial and femoral angioplasties were also the same in red and blue. So we could find no difference in radiation exposure. John Davis down there is one of these operators. This is from 2003 to 2004, when we had 5 angioplasty operators, and these are their personal doses, and I'm operator C. And these 2 operators, A and B, were femoral operators, and we're getting considerably more radiation than me. More recently, we've looked at the entire world literature on radiation exposure. This is a plot of how it's changed over time. You can see that the early studies perhaps showed some increases, but our study is down here, and in fact, the most recent studies show that the radial is probably better than the femoral. So the idea that radial access increased your radiation exposure was a myth, nonsensical myth. There's ways you can reduce your radiation exposure, and we're looking at some of these in the cath lab at the moment. This is a simple little thing that sticks up between the patient and the operator, and it screens out some of the radiation. You can see it drops the dose by about 20%. This is a a lead shield draped over the abdomen and pelvis of the patient. It stops the radiation scattering back from the patient and hitting the operator. And here you can see you get about a 50% reduction in radiation exposure with this measure. And my personal radiation exposure is less than, every year is less than if I moved from New York to Denver. It's negligible because I'm quite careful with it and I'm good at radiation protection. It's nothing to do with the access site. The next thing that the femoral operators thought was an obstacle was that you get more strokes. Now, they had no data about strokes. They just said you get more strokes. It was their idea. They manufactured this idea in their heads as a reason not to do radial procedures. They said it was because when you introduce the catheter from the radial artery, you have to go down this brachiocephalic artery and you cross these two arteries that do supply the blood supply to the right side of the brain. And when you come from the femoral route, you don't do that. And that's true. You do traverse those vessels and there's potentially an embolic risk. What they neglected to take into account was the fact that in the ascending aorta, the only part of the aorta that's traversed by a radial operator's catheter, there is no atheroma, but in the arch and the descending aorta, there's 40 to 60% incidence of complex atheroma, which is a major source of emboli. Now, if you take patients who have this and you catheterize them in this early study from 1996 from the leg, 17% incidence of emboli, catheterize them from the arm, it was brachial cut-downs there, 0%. So it's likely that those two set of factors, traversing the head and neck vessels or traversing the atheromatous aorta, counteract each other or play each other off. We set out to study this by looking at the British Cardiovascular Intervention Society database. And BCIS has run for many years. It collects data on every single angioplasty performed in the UK, 130 different parameters, and it records every stroke that happens. It's linked to mortality using the patient's NHS number through a central register. It's a legal requirement for every death to be recorded. So we looked at almost 350,000 angioplasty procedures, and we documented the incidence of stroke for radials and femorals. And this is what we found. The incidence of stroke after angioplasties is rising, but it's not different for radial in blue or femoral in red. In fact, you know, in the most recent years, it looks as if the radial incidence is lower. So there was no excess of stroke once we looked carefully. And you know, more data has emerged from randomized trials. If randomized trials are your thing, this is the Rival trial, 7,000 patients. Incidence of stroke, 0.2%, very similar to what we found in the UK database and identical for radials and for femorals. The next thing was, okay, well, maybe you don't get more radiation, maybe you don't get this, maybe you don't, but it's not worth all the effort. I can't, you know. It's not worth it. I'm not doing it. It's not worth the effort. So we looked at all of the randomized trials of radial or femoral access for primary angioplasty in patients having a heart attack. Anything that lies to the left of this line favors radial access. Anything that lies to the right of this line favors femoral access. And this is what we found. Overall, in the radial group, there was a 50% reduction in mortality. So you were twice as likely to die if you had your angioplasty performed femorally. So we published this. There was a whole host of hostile letters and reactions sent in, one of which was that this wasn't very relevant because it was only a small number of patients in highly selected populations. We went back to the BCIS database. We looked at nearly 50,000 patients. This is survival for femoral primaries, survival for radial primaries, 30% mortality reduction in 50,000 unselected patients. If you ask any patient, do they want to live longer? They're only going to give you one answer, and that's going to be, can you please do it radially, doctor? Don't puncture that artery in my leg. It's not good for me. We've looked outside the primary angioplasty population. Karim, my research fellow, analysed this data. It's nearly 450,000 angioplasty procedures, blood transfusion less common for the radials, vascular complications less common for the radials, and mortality was reduced. And when you look at the different patient groups, if you look here, these three dots, these three bars lying to the left of the line indicate reduced mortality for radial procedures over femoral procedures. For stable patients, for patients with small heart attacks, and for patients with big heart attacks. And the same pattern for other complications, for bleeding, and for access site complications. So in nearly 500,000 people with a variety of simple and complex angioplasties, we were able to show that radial access was still beneficial. There's a way of closing the puncture hole that you've made in the femoral artery with an expensive and complicated device. It implants a small amount of material which is derived from a cow's bottom into your femoral artery, where it will stimulate coagulation and close the artery. And so the femoral operators then said, well, you know, we can do better now. We've got these closure devices that we can put in, and that will be great. And we don't need to do those radial procedures. But this also was a myth. Transfemoral access with closure devices in our large, nearly half million patient cohort. The radial group in red. Okay, 30-day mortality, much better for the radials compared to the closure devices. Other major cardiac complications, much better. Bleeding halved. Access site complications, much less frequent. So the closure devices are definitely not the answer. The last and maybe latest thing that they came up with was that you have to stop doing all these radial procedures, or you won't be able to do femoral procedures anymore. You'll get useless at doing femoral procedures. The idea that, you know, someone like me or all the other radial operators who can work in that diddy little artery and overcome all those problems won't be able to anymore puncture a huge, great femoral artery, it's laughable, really. This is what we found when we looked across the database. This is femoral procedures done in radial hospitals in red and femoral procedures done in femoral hospitals in blue. Okay, mortality was lower in the radial hospitals. MACE rates were lower. Vascular complications were the same. Bleeding was the same. So the radial guys can do the femoral procedures just as well, if not better, than the dedicated femoral operators. So it was quite a journey to collect all that data and present it. And at the same time, we were involved in a lot of education and training in the department. Julie Stubbs down there has been helping me and Jenny all along. We ran a lot of courses. Here's a few of them. We ended up last year running the big international meeting, which we ran up in Liverpool just because it was logistically easier to do that. But all the time, over that period of time, since 2008, at the beginning, for the first 5 or 6 years, we had other doctors, other consultants in the lab with us, sometimes 2 or 3 times a month, trying to teach them how to do the procedures. I mean, I learned a lot, really. I realized when I came back, after a while, I realized that I could do them, but I couldn't really tell other people how to do them. I had to learn what it was that I was doing, that I could help pass that information on to other people. So we ran a lot of courses. We wrote a lot of things in textbooks. We published these important review articles, the state-of-the-art article that told people how to do them. We argued here with my colleague Marshall Hamon from France about that everyone should have a radial procedure. And here I ended up working with the European Society of Cardiology and published this position paper that recommended that everyone should have radial procedures and how they should be done. And, you know, you do wonder after all of that, because it was hard work, was it worth all the effort? And this is what's happened to arterial access site practice in the UK. So the first 5 years, it took 5 years to get from me on my own down here, doing all the procedures, to 10% of the procedures being done radially. And here we are in 2014, 76% of all the angioplasty in the UK is performed radially. The rate's still going up. I don't know where it will stop, 85, 90, 95. There are people in the UK who do 99% of all their angioplasties radially. It wasn't completely homogeneous. We're here. The darker colours represent areas where radial procedures are frequent and the lighter colours less frequent. This was how the map of the UK looked in 2005. You can see the red colour spreading out from us. Conquered Wales there, the north of England. 2009, starting to look good. And here we are in 2012. There's still a couple of London and the southeast. Don't go down there, have a heart attack. If you do, get in a train, come back up here. Some bits of Yorkshire, strangely. It's kind of interesting to look at what's driven the changes. Is it the data? I don't think it is really. This is when we started to publish the big papers. This was the first 1,000-patient paper that we published. This is the big data sets that we've been working with on, and here the randomized data. But when you look at when we started to run all the courses, down here, and to start, we organised a fellowship in the hospital where I'd worked in Amsterdam, so we sent other UK trainees over for 6 months at a time. Probably the education and training initiatives had a big impact on what happened to access site practice in the UK. So I'll end up with a few pictures. I know you all like pictures. You can have problems with radial cases. This is one we reported early on. We used to occlude the radial artery with a tourniquet that was completely occlusive. It stopped venous flow, and this patient had a deep venous thrombosis in the arm because we'd stopped the flow. We don't use the tourniquets anymore. We've got unilateral compression devices. This is 2 of the 3 complications from that first 1,000 patients. A pseudoaneurysm, and what we thought was a skin infection. It was, in fact, a reaction to the coating of the shields that we were using at the time. This is kind of interesting because the vascular surgeons came and looked at this. They took the patient to the operating theatre. You can see a little skin incision here, and they just made a little incision and tied the radial artery off, and the pseudoaneurysm disappeared. They weren't bothered because, of course, there's a dual blood supply there. This is an ultrasound of the pseudoaneurysm. You can see this big, this is the radial artery, this is the pseudoaneurysm. It's a big collection of gunk with blood flow into it. This is a CT reconstruction of a pseudoaneurysm. You can see there's a little neck that leaks blood into this big circular sac. This is an AV fistula. This is the radial artery, and this is a vein, and there's a communication between them. I've only seen one of these in the whole time I've been doing the procedures, nearly 20 years now. The patient, he is a patient of mine. He doesn't want anything doing about it. He's not really bothered by it. Might be quite useful to him in the future if he gets renal failure. This used to be a problem, a radial perforation. If we perforated the artery in the forearm, if you can't stop the bleeding, the forearm can swell up. And if you get too much blood in there, the pressure in the arm can rise and cause major problems with the vascular and neurological supply of the arm. Now, we see these not uncommonly, but nowadays we deal with them much better by putting a sheath up or a catheter up. We don't stop the procedure, and if you leave the catheter up there for a while, the perforation seals itself off. One way of dealing with a big forearm hematoma is leech treatment. You might think it's odd that a hospital in 2016's got leeches, but every hospital's got them somewhere. The vascular surgeons and sometimes the plastic surgeons will use them. So they stick them on your arm, they stick the blood out, drop the pressure. If that doesn't work, you can do this. I've never seen one of these. If the pressure gets too high, you have to incise the arm, let the pressure drop. This is a radial artery that a strong cardiologist has pulled out of a patient. Probably best to avoid this cardiologist. If you can't get the sheath out, don't pull it too hard, would be my answer, you know. There are ways of getting them out rather than pulling them, because that's what happens. You can pull the whole artery out. This is a bleed into the chest from a subclavian puncture, so you can get these complications. They're usually easier to deal with. And when you get them, this is just one series, 3,369 consecutive patients, 0.06% incidence of complications. And they were all minor, and they were all dealt with without vascular surgical intervention. So I'm going to kind of stop. You can always do better in clinical practice. I think it's clear that you can risk stratify heart failure patients by analysis of heart rate changes. You don't even need to do the complicated stuff that I started out doing. You can just look at the heart rate range, the equivalent of a pencil. Radial access is the optimum way to do angioplasty, but you know, it's quite clear that people don't like change. The establishment, if I can call them that, don't like change, and they don't like challenges. And so here in North Staffs, we were outliers really, outriders. We were the first people to set up a big program, but I do think we've had a big impact on national and international practice. The unit has a reputation worldwide. Going forward, we've got bigger plans. Prof. Mamas, my colleague down the front here, has joined us from Manchester. We're setting up an expanded cardiovascular research group to really work in a much more organised way going forward. So I'll end up with a few thanks. To the staff at the hospital, particularly Julie Stubbs and Jenny Pickrell down there. The only 2 members of the cath lab team are still here from when I started. Rachel, my secretary, has been fantastic over the years. And to all my consultant colleagues, and to John, where is he? Down there, who's driven up from Plymouth, which is really nice and was a fantastic mentor to me in the first 5-10 years I was here. To Tony Berry at the North Staff's Heart Committee, who gave us the money to buy the equipment to do a lot of the research. And has funded many components of the clinical and research program in the hospital over the years, and to Ted and Karim, my 2 research fellows who collected a lot of this data and did a lot of the work. In setting up the cardiovascular research unit, I really should say thanks to the management team at the hospital. You know, hospital managers sometimes get a bad press, but they're not all bad guys. They're often trying to do the same thing as us. Mark Hackett, the chief executive, is a fantastic guy and has helped us, along with Andy Garner from Keele, in setting up the cardiovascular research unit and recruiting mammoths. And of course, to all the family, some of them are here tonight. I've got a big extended family in Liverpool and North Wales. It's a fantastic thing to have. These are the two most important ones. This is the missus and the little boy. This was his first day at school in September at about 8:15 in the morning. This was at 4:30 that afternoon. And, you know, in that kind of circular way of lectures and life, one of my roles in his life is to make sure he supports the football team. He's got this in his bedroom. Thank you.